we move thirdly, ladies and gentlemen, to Professor Catarina Chaves, who's Head of General Bacteriology, Clinical Pathology Service at Coimbra Hospital and University Centre in Portugal, who's going to continue on the theme of rapid diagnostics and talk on rapid phenotypical antimicrobial susceptibility testing, laboratory implementation, and its impact on patient management. Catarina, the floor's yours.
Thank you so much for being here, ladies and gentlemen. So I will talk a little bit of rapid phenotypic antimicrobial susceptibility testing and the implementation of this novel workflow and the impact on patient management. It's important to talk about some topics in my presentation, and these topics will be covered 5 points very important. Our hospital center, SHUC, Centro Hospitalar e Universitário de Coimbra, is the largest healthcare center in Portugal with over 2,000 beds and almost 1,500 patients consulted per day. Our main goal is to report and communicate with clinicians. We have a team that communicates every day with clinicians at wards. We test all the samples for COVID-19, including all of the samples from emergency department, and we use for the tests of SARS-CoV-2 3 platforms: the Cepheid Gene Expert, one platform from Menarini, and another PCRs with methodology more conventional. Our laboratory receives samples 24 hours every 7 days of the week. It receives all samples from all hospitals in SHUC system, one lab, 5 hospitals, but it also receives specimens from other institutions. I've got an example of the epidemiological study from the ICU for the year of 2020. For the intensive care unit, we have 3 problem microorganisms: the E. coli, the Klebsiella, and Staphylococcus aureus. What is important too is to know the pattern of the resistance, and we know that for these units, almost 24% of the Klebsiellas are resistant to carbapenems. All these of Enterobacteriaceae are KPC, so carbapenem is not an option to treat our patients. There are many recommendations that provide new standards for bloodstream infection diagnostics, and this paper is very good. It has many topics that I recommend, and these diagnostics are based on a bundle approach of optimization of pre-analytical parameters, of rapid start of blood culture incubation, rapid diagnostic methods, the laboratory reorganization. It's very important to work 24 hours for 7 days, a good transportation service, and the close involvement of antimicrobial stewards teams. The continuous improvement of bloodstream infections, it's very important in the diagnostic process because it's based on a sample quality and the time to results. It's important to the priority to improve the patient outcome, and our goal too is avoid unnecessary antibiotic treatments. What is very important for us in the laboratory, and for this presentation we'll focus in 2 topics. We know that the rapid diagnostic 24 hours for 7 days, the rapid AST and the rapid identification is very important for these patients. And what is behind these rapid diagnostics? It's behind the optimized treatment, the consultants, and the antimicrobial stewardship. So this is our goal in our project implementation. The future goal is to expand to emergency department and general floor patients with clinical signs of sepsis with or without a positive blood culture. We make rapid diagnostic tests for blood cultures by BioFire film array, Cepheid Gene Expert, Bruker Septityper, or Accelerate Phenosystem. You have many possibilities to the diagnostic of bloodstream infections or sepsis. Many clinicians at our healthcare center prefer susceptibility results because with MICs we can select antibiotic, we can have a dose frequency of these antibiotics. We have introduced rapid diagnostics patient-specific workflow in microbiology laboratory. What we have at word a clinical suspicion of sepsis, then a set of blood cultures are collected, and these blood cultures are incubated in an automated system. So the blood culture turn on positive, and at the lab, the microbiology clinical team will be discussing with the clinician what is the better decision for the patient. So we have many possibilities. We have methodologies with PCR multiplexed, with the identification of the microorganism, identification of genes of resistance in about 1 hour. We have phenotypic identification and antibiotic susceptibility testing with MICs in about 7 hours. And we have also the direct MALDI identification and traditional AST about 18-48 hours. What happens in these blood culture positives? In the unit, the nurse attach a sticker to a blood draw bottles from patients with signs and symptoms of sepsis. So this identifies the high-risk patients for rapid tests. In the lab, the microbiology clinical team performs an antimicrobial stewardship function. So it provides microbiology consultations focusing on ICU patients. So here we have a picture of what we do every day. So we have a blood culture turn on positive, and we have the traditional methods with traditional AST and results, and we have the phenotest methodology with a rapid identification and AST, 1 or 2 days faster than the traditional methods, and we have a rapid result with adjusted antibiotic therapy. This phenotypic AST option has an option for a sepsis fast track workflow because the time to identification is less than 2 hours, and because the time to AST results with MICs is almost 7 hours for multiple gram-negative and gram-positive antibiotics. So the MICs enable the optimization of the antibiotic choice, the dose of the antibiotic, and the dosing frequencies. There are extensive publications about these matters that demonstrate the reduced times to stewardship interventions. So our lab is focusing in this matter. In our lab, with the use of accelerated pheno system before the COVID-19 pandemics, we have some identification from several blood culture positives. The origin of these microorganisms are the pediatric ward, the intensive care units, the burn units, and other units that have patients with signs and symptoms of sepsis. With COVID-19, everything was changed. Under pandemic conditions, it was very difficult to implement a sepsis quality improvement, but we didn't give up. So how has COVID-19 impacted blood culture diagnostics and management of bacteremia? There are several studies in other countries, in other institutions, and we have our reality. This paper is very important because it talks about the impact of combating the COVID-19 on blood culture contamination and central line associated bloodstream infection rates. And we can see in these figures that the blood culture contamination had high rates, also increase in central line associated bloodstream infection rates. So an enormous burden on healthcare research and increased quality. We have 4 more papers from Spain, of United Kingdom, or United States, or even Japan. In New York City, United States, we have an increase of utilization of blood culture, but in Spain, we have a decrease in number of blood cultures. There are different realities. In our healthcare center, the blood culture volume decreased 18.3%. For blood culture positivity rate, we have nearly the same rate for 2019 and 2020, but for blood culture contamination rate, we have 4.8 for 2019 and 5.8 for 2020. In 2020, our focus was on COVID and respiratory infections. Some clinicians developed with a blindness toward patients with signs and symptoms of sepsis, and this give us an extra motivation to continue this blood culture and sepsis improvement project. We can see in this figure that in 2019 we performed 65 identifications and AST with phenol system, and in 2020 we performed 296 tests with identification and AST with MICs. During COVID-19, here we have the distribution by wards between March 2020 and April 2021. We introduced not only the pediatric ward and the COVID ward, but also the emergency department, because mainly most of the patients that we treat were from this unit. Here is a little bit more of the same data. We have the distribution of the identification of microorganisms identified by accelerated phenol system between these periods. So the major advantages of this phenol test, it's not only the identification of microorganisms in about 1 to 2 hours, but the major advantage is really the MIC for the antibiotics for gram-negative microorganisms. And for this epidemiology in our hospital, with the utilization of phenol test, we have for all Klebsiellas, 30 Klebsiellas, we have 7 resistant to meropenem. So it is very important to report this pattern of resistance to these strains. For Pseudomonas aeruginosa, we have 3 strains with susceptibility decreased to meropenem, and we have 2 of these strains resistant to colistin. These are data very important to adjust the antibiotic therapy in our patients. So rapid results are interpreted by microbiology clinical team, and we have an early adjustment of empiric therapy and an early antibiotic optimization. They are our goals in our lab. So let's talk about 3 examples of real case reports in our healthcare center. So the first case report is from a 61-year-old man from emergency department that presented with fever and respiratory failure, low blood pressure, and acute renal failure. At this point, before he started the antibiotherapy, it was collected 1 set of blood cultures, urine culture, and it was performed a test for SARS-CoV-2. So he started antibiotherapy with meropenem. So for this patient, we have with the phenol tests a result for almost 19 antibiotics less than 24 hours from a blood draw. So the antimicrobial stewardship goal was achieved with reduced carbapenem consumption. This patient was discharged to general ward, and it have a resolution of sign of infection in next days. So the antibiotherapy for 7 days, the right drug with the right time was fine adjusted for this patient. With this workflow, we can have an antibiotic decision almost 1-2 days faster than the traditional methods, and this is very important to the improvement of antibiotic therapy. For the case report number 2, we have a 58-year-old woman at COVID intensive care unit, SARS-CoV-2 positive by gene expert methodology. On day 3 of stay at the ICU was identified a Haemophilus influenza beta-lactamase producer by a biofire respiratory panel. And at this day, number 3, in COVID ICU, this patient was placed on amoxicillin clavulanic IV. At day 7 in ICU, procalcitonin and the CRP are increased values, and the blood culture turned on positive at day 7. It was performed a gram stain, and the microbiologist observed gram-negative bacillus, and the amoxicillin with clavulanate treatment were continued. with the identification of a Klebsiella SPP performed in accelerated pheno system, and the result was reported at 7:40 p.m. The pheno AST results were reported at 1:40 a.m. with results for amoxicillin clavulanic resistant with a MIC of 16, the result of piperacillin tazobactam with MIC superior to 16, also resistant, and the susceptibility for meropenem with MIC less than 0.25, and these results were reported at 1:40 a.m. And these recommendations were reported by microbiology clinical team to the clinician, and there was a rapid escalation to meropenem in this specific case. So at time 0, we had a blood culture collection. 6:30 hours later, we have a signal positive at the blood culture collected. We have 2 hours and 10 later an identification of the organism, and we have 5 hours 30 later antibiotic susceptibility testing performed. So the antimicrobial stewardship goal was achieved, a rapid switch from the inactive to an active therapy, so it's make sense for us. The antibiotic de-escalation to an active optimized therapy achieved 1-2 days, faster than the alternative Shook laboratory workflows, the traditional methodologies. And in the following days, the PCT, the procalcitonin in cellular assays, was decreased. So it's fine for us and the therapy is okay. The blood cultures were negative after 7 days of meropenem, so we have the success of our treatment. The case report number 3 is a patient in burn unit, a 45-year-old man with 45% of TSP burn, the total body surface area. This patient had no airway compromise. This patient is on day 14 of hospitalization, and the value of procalcitonin is increasing. So the blood cultures are collected at 9 a.m. before the antibiotic is initiated, and this patient starts meropenem and vancomycin by a multidisciplinary decision between the microbiological team at the lab and the clinician team at the ward. The blood cultures turn positive after 8 hours of incubation, so they turn on positive at 5:40 p.m. It was performed a gram stain with gram-negative bacillus, and so at 8 p.m. we have an identification of a Klebsiella SPP, and we have at 5:30 hours a report of susceptibility and MICs for multiple antibiotics. So we can see a really report of our pheno system, and we have the MICs at the right, and we have the susceptibility pattern for meropenem with a MIC lesser than 0.25. So it was our therapeutic option. The result was reported by microbiologists into Shook medical record system. The result also was reported via mobile phone directly to burn units, and the decision made to continue meropenem and stop vancomycin treatment was performed. The patient had a resolution of signs and symptoms of infection, and the monitorization with sepsis markers were performed, so it demonstrates that it was a success, these diagnostics and antibiotic prescription. In summary, it's important to know that clinical microbiologists are needed 24 hours for 7 days. The rapid diagnostics are critical to quality improvement project focused on blood culture diagnostics and management of bacteremia or sepsis. The implementation of a new clinical microbiology rapid diagnostics, a new workflow or new logistics is challenging but possible even during the pandemic. As the outside world focuses almost entirely on COVID-19, clinical microbiologists and infectious disease must balance patient priorities and pay attention to other conditions such as bacteremia and sepsis. There are several publications reporting the COVID-19 impact on blood cultures. the number of blood culture collected, the BC positivity rate, the BC contamination rate. It is important for stewardship and microbiology laboratories to know the trends in their institution. And this new COVID-19 age has provided new challenges. It's a challenge every day for the clinicians and for clinical microbiologists in optimizing diagnostic techniques with the goal of improving patient outcomes. Thank you so much.